Good afternoon, everyone. It's fantastic that you could join us for this great session that we've got today. My name is Andrew Watkins, and I'm the Director of Programs and Innovations with Mindgardens Neuroscience Network. I'm really pleased to chair this webinar. And firstly, I would just like to start by acknowledging the strength and resilience of Aboriginal and Torres Strait Islander people, who are the traditional custodians of the diverse countries from which we're joining this meeting. I'm privileged to be calling from Gubbi Gubbi country, and I pay my respects to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also want to acknowledge people with lived experience of mental ill health and recovery, and the expertise of people who have been carers, families, and supporters. They are the people that shape what we do and why we do it. Welcome to everyone to the Mindgardens Psychosis Webinar Series, which is part of the Mindgardens Tertiary Referral Service for Psychosis, or TRSP. TRSP is a statewide service that is funded by New South Wales Health and hosted by South Eastern Sydney Local Health District. And Mindgardens is very grateful for both CESLED and New South Wales Health for their ongoing support of the TRSP. TRSP aims to improve the lives of people living with complex psychosis. It does this through delivery of clinical service, which welcomes referrals from right across the state of anyone living with psychosis and receiving care from public mental health services. It also runs education and training programs to build capacity in caring for people with complex psychosis. This webinar series is an example of that capacity building. This webinar series is supported by us, Mindgardens Neuroscience Network. For anyone that might be unfamiliar with us, Mindgardens is a partnership between member organisations, Neura, Black Dog Institute, UNSW Sydney, and CESLED. Mindgardens was established in 2019 to enhance the collaboration between the members, bringing together clinicians, researchers, and health service administrators, and people with lived experience to design, research, and quality improvement projects that can be translated into everyday practice, matching consumers' priorities to make a real difference in people's lives. This psychosis webinar, which is run throughout 2025 monthly, and we have one more to go this year, so please keep an eye out for emails from Mindgardens, which will detail future webinars that are tailored for all clinicians. And a little bit of housekeeping for the rest of this webinar. You will have seen a poll question just pop up now, and there'll be a couple more before the end, so we'd really appreciate you answering. Your answers are anonymous, and they help us constantly improve these webinars, which will run again next year in 2026. There will be a Q&A session at the end. We have a little Q&A icon that should appear on your Microsoft Teams. So please put any questions you have in that window during or just after the presentation, and we will endeavour to answer as many of these as possible. We would also appreciate any feedback that you might have to be placed in the chat window, either now or via email later on. If your question, we don't get a chance to answer the question that you've asked during the presentation, we will endeavour to get an answer from today's speaker and reply to you on that by email. Just a reminder that our email address, if you do want to get in contact with us, is contact@mindgardens.org.au. This webinar will be recorded and distributed to all registered attendees within 2 weeks, so please keep an eye out for that. Finally, it's my great pleasure to introduce our guest speaker for today, Dr. Nicholas Burns. Nicholas is Chair of the Royal Australian New Zealand College of Psychiatrists Section for Social, Cultural and Rehabilitation Psychiatry, and Clinical Lead in Rehabilitation Psychiatry for the New South Wales Ministry of Health. He is interested in the social determinants of mental health, and in particular, the relationship between homelessness and mental illness. Nicholas consults to several homeless men's shelters in inner Sydney and works clinically as a forensic psychiatrist with extensive experience in forensic rehabilitation, working initially in secure settings and more recently community-based forensic rehabilitation. Nicholas is also a member of New South Wales Mental Health Review Tribunal's Forensic Division and an honorary senior lecturer in the University of Sydney's Rural School of Medicine. So you will see that Nicholas is very well qualified to present today on the presentation entitled Defining Rehabilitation Psychiatry with both the academic and real-world practice background. Please join me in welcoming Nick, and I will pass over to you now, Nick, to continue the presentation.
Great. Thanks, Andrew. I've just shared my screen. Can you guys see my screen? It's coming up okay?
Yeah, it's all good.
Okay, great. Thanks. Okay, good afternoon, everyone. And thanks, Andrew, for that glowing introduction. Just to clarify, hang on a minute. I'm just going to see if I can. Yeah, here we go. Okay. Yeah, just to clarify, I am primarily a clinician. I'm not an academic. I did work in a forensic rehabilitation service for many years, so I do have that clinical experience. But just by way of background, a few years ago, I became chair of an interest group within the College of Psychiatry that has an interest in social and rehabilitation psychiatry. And I have also taken on a part-time role as clinical lead in rehabilitation psychiatry with the New South Wales Ministry of Health, which is about trying to build partnerships and clinical leadership amongst psychiatrists working in rehabilitation psychiatry. So when I took on these more official roles, it stimulated a question for me around what is rehabilitation psychiatry, and furthermore, what is a rehabilitation psychiatrist? Because my experience had been really that psychiatrists working in non-acute settings haven't really called themselves rehabilitation psychiatrists. There is no training pathway through the College of Psychiatrists for people who want to be a rehabilitation psychiatrist. And indeed, a lot of people who ended up working in rehabilitation, I must confess, had come from acute services where perhaps they were looking for work that would be at a slower pace. But so this question has a very personal resonance for me. I hope you'll indulge me. And what I will show you here is, I guess, a summary of my investigations as to what is rehabilitation psychiatry, and is there such a thing as a rehabilitation psychiatrist? And a few other questions that you'll see here that we'll look at. So another much used term is recovery, often used interchangeably with rehabilitation. So looking at how those two entities may differ. Looking at some contemporary best practice guidelines for rehabilitation psychiatry, and then finally looking at the various ways in which we can evaluate rehabilitation services. And before starting, I would like to acknowledge the Gadigal people of the Eora Nation, who are the traditional custodians of the land from where I'm joining you today. And I honour the ancestors of yesterday, the custodians of today, and those of tomorrow. And like Andrew, I'd also like to acknowledge all people who have a personal experience of mental illness as well as their carers and loved ones. The voices of people with lived experience are essential in the development of our work, and it's why we're all here today. So In my quest, I went back to looking for some basic definitions. So this is a definition for rehabilitation. Rehabilitation addresses the impact of a health condition on a person's everyday life by optimizing their functioning and reducing their experience of disability. Rehabilitation expands on the focus around prevention and cure and moves beyond that to ensure that people with a health condition remain as independent as possible and can participate in education, work, and other meaningful social activities. So we're seeing some important themes here emerging. I looked for some specific definitions of what psychiatric rehabilitation is. And in my quest, I went to the UK's Royal College of Psychiatrists. They have a faculty of social and rehabilitation psychiatry. And this definition appears on their website, the homepage of their website. And I think it's worth interrogating. Rehabilitation psychiatry is a whole of systems approach to recovery from mental illness that maximizes an individual's quality of life and social inclusion by encouraging their skills, promoting independence and autonomy in order to give them hope for the future and leading to a successful community living through appropriate support. So it's got, in that very dense paragraph, a lot of the key concepts for me. The second definition I took from the other side of the Atlantic, from the Boston School of Rehabilitation and endorsed by the National Institute of Health in the US. And you'll see here that this definition actually is pretty close to that of the UK College. So they talk about promoting recovery, community reintegration, improving quality of life for anyone who has been diagnosed with any mental health condition, so they're not specific about that, and a condition that significantly impairs someone's ability to lead a meaningful life. And they add further that psychiatric rehabilitation services should be collaborative, person-centered, and individualized. So we've got some key terms emerging and certainly helped me in understanding what rehabilitation is about. And here are some of the core features. It's a value-based care, and we'll talk a little bit about that more. It emphasizes enhancing functional improvement rather than symptom resolution. It aims to reduce disability. So a disability is something that restricts someone's ability to participate in activities in the community. So such as work or employment or other social activities. So rehabilitation aims to reduce disability and promote social inclusion. It's strength-based recovery. In other words, rather than focusing on deficits, it's trying to assess and understand the individual's strengths and enhance those strengths. It involves the service user in decision-making about their own treatment. And ideally, it provides the consumer with choice in terms of the type of interventions that they may or may not want to participate in. It instills hope and helps to optimize the patient's experience of treatment. It highlights the importance of the therapeutic relationship. So Anthony and Farkas, who are from the Boston School, have said that paramount to this process is the relationship between the practitioner and the consumer. So that relational aspect of care is really important. And finally, these values that we've talked about have an evidence base in the behavioural science literature that shows that people change positively in the context of a positive relationship when they set their own goals and are taught skills to achieve those goals. So we're not just doing these things because they might feel right or feel good, but there's actually a scientific evidence base to say that it works. So more on theory later. So for me, I then went back to look at the historical emergence of rehabilitation psychiatry, because really from the birth of what we understand as kind of Western style contemporary psychiatry, the majority of that has been, the care has been based in institutions and asylums. And there was no differentiation between rehabilitation and general psychiatry, or indeed any other aspect of psychiatry. So I think it's good to start with looking at the dawn of the Age of Enlightenment and moral therapy, which was really at the first prototype of modern psychiatry as we kind of understand it. And it was at a time when prior to this, people were kept in insane asylums in really barbaric and inhumane conditions, often chained for many years at a time, and people never emerged or rarely emerged. And there were various locations in the UK and in France where a different way, a more humane way of treating people commenced. And what you see there is a photo or an image of the York Retreat, which was started by William Tuke, who was a Quaker, not a physician. And he had noticed firsthand some of the barbaric treatment of some of his religious community. And so he decided to start up a retreat where people were treated in a much more humane way. And just reading from this excerpt, it sounds very familiar, really, to some of the values and tenets that we hold for rehabilitation services today. So their approach emphasizes humane, individualized care, including compassionate interaction, occupational therapies or activities, and a supportive environment. And furthermore, it aims to promote dignity and promote character development. So this sounds very similar to the kinds of the values, I guess, that imbue my understanding of rehabilitation today. Then, unfortunately, asylums fell into a long period of inertia to some extent. Between about the 1800s and the 1950s, there was a steady rise in the population of institutions in Western countries, up until the point here you'll see on that graph, about the 1950s, when there was a dramatic drop in the population of asylums. And during that period, mental illness was really seen in very organic biological terms, and also in very nihilistic terms, that it was these were conditions that were hereditary and degenerative, and there was no expectation that people would recover. So many people who were admitted to asylums, in fact, died there, and very few people were successfully reintegrated into the community. These became homes for life, and there was no expectation that people would move on. And naturally enough, they became overcrowded and places where people were subject to abuse. So in the 1950s, there were some key changes that led to a dramatic decline in institutional care. First of all was the development of advances in biological treatments and also psychological treatments, with the discovery of antipsychotics, the phenothiazines, and tricyclic antidepressants. It was a time of significant social and political change. And in the 1960s, in the context of what was called a counterculture, which was questioning the institutions and authorities of society at the time, there was the birth of the anti-psychiatry movement. And there were some seminal texts such as Irving Goffman's treatise on asylums, which highlighted the dangers of mental asylums and the way, in fact, they were making people worse rather than making people better. Michel Foucault's Madness and Civilization, and Thomas Sass and R.D. Laing, who really questioned the authority of psychiatric diagnosis, the treatments available, and highlighted the neglect and abuse of power that was taking place within institutions. And this was coupled with the civil rights movements, which eventually led to the disability rights movements and further the recovery movement, where people were given more agency in decisions around their care. And the hierarchy, the power hierarchies became more horizontal rather than vertical. So in 1975, the International Association of Psychosocial Rehabilitation was established, and there was an emphasis on increasing the number of models of care for people in the community, and eventually followed by consumer advocates' involvement in mental health care, and finally recovery orientation to mental health practice. And similar changes happened as a result of the Burdekin report and the Richmond report in this country, leading to all of the changes that we've already mentioned, with much shorter stays in hospital and a focus on community care. So just returning to the theoretical underpinnings, and I just want to reiterate this statement because I think it's really important. People change positively in the context of a positive relationship when they set their own goals and are taught skills to achieve those goals. So, I think what's really important here is that this is emerging from the social and behavioural sciences. It's not a theoretical underpinning coming from the biomedical or biological sciences. And I've listed here just some of the important theoretical constructs that I think have informed contemporary rehabilitation practice. These include Carl Rogers' humanism, which emphasises or is underpinned by the notion that we all have innate drives towards self-improvement and self-actualization. And our role is to help people achieve that potential. And it forefronts the importance of free will and self-determination. I think the biopsychosocial model, which we all know and talk about now, but in the 1970s, that was a revolutionary concept because psychiatry was very biologically driven at the time. And this highlighted the importance of social and cultural context, both in the etiology of mental illness, but also in considerations for treatment. Community support theory emphasises the importance of shared resources and strong social networks for improving health and resilience. And the strengths model emphasises the notion that we all have innate abilities and resilience, and the role as therapists is to build on those innate strengths and enhance them. Occupational therapeutic models have been really important, including the model of human occupation and Claudia Allen's cognitive disability model, all of which highlight the importance of having a social function and meaningful roles in the community for improving someone's mental well-being. And I really like the self-determination theory, that is a theory of a motivational framework, really, that again says that humans have innate tendencies for growth and mastery, but they may need help with autonomy, which is around a feeling of choice, competence, which is around the sense of feeling effective, and relatedness, strengths of social connectedness. And finally, salutogenesis, which I've mentioned here just because it foregrounds the importance of understanding the individual's story and lived experience. So just to reiterate, some important principles that, in my mind, from my research, that are key to rehabilitation psychiatry. So self-determination, the dignity of risk, and allowing people to make their own choices, supported decision-making, even if we think they may not be the best decisions. Attending to someone's personal goals and preferences, not just the clinicians. It has a real-world focus for trying to enhance someone's participation in the community. It has a focus on strengths, skills training and development, environmental modification and supports, a focus on community reintegration, and a recovery orientation. And we'll talk a little bit about what recovery is as opposed to rehabilitation. And these are some of the systemic features which are a little repetitious, but just to note here the importance on respecting people's lived experience and their expertise in understanding their own conditions and the things that will help and the things that will make things worse. And also to highlight hope orientation. Okay, so here I want to look at the differences, if there indeed are any, between rehabilitation psychiatry and general psychiatry, because this has certainly been a question for me. This is not a definitive answer, by the way. I've taken a lot of this from a talk I attended by a psychiatrist called Frank Holloway in the UK, and this has arisen out of discussions also with colleagues in other jurisdictions. But I'm keen to know people's views about this. So rehabilitation focuses on functional recovery, whereas general psychiatry tends to focus more on symptom remission. And here I'm thinking, if we're thinking about the acute context when we're trying to reduce someone's acute psychotic symptoms or mood symptoms or anxiety symptoms. Rehabilitation tends to focus the need to work with someone. We call it walking alongside someone during their recovery journey. In contrast to general psychiatry, where perhaps there's more of a focus of doing to. In rehabilitation, we aim to give people choice and promote agency in their own treatment. Whereas in general psychiatry, there may be more of an emphasis on voluntary, involuntary treatment, and even if not involuntary treatment, treatment where people aren't given as many options. In rehabilitation psychiatry, we try to address the social predicament, whereas in general psychiatry, it is more of a focus on the clinical predicament. In rehabilitation, we focus on the person's life goals, whereas goals may be determined by clinicians in general psychiatry. We have the privilege of a longer time frame, and certainly I know in acute psychiatry where perhaps in inpatient services people are admitted for 8 days, there's very little time to establish a therapeutic relationship, which in rehabilitation is a key clinical tool, really. Furthermore, in rehabilitation, we really try and understand the potential negative impact of our treatment and our treatment environments and modify that. And I think this is crucial, the need to foreground combating therapeutic nihilism. And I'll talk about why that's so important. Okay, so I still struggle in my mind as to whether general psychiatry and rehabilitation psychiatry are all that different. Are we comparing apples and oranges? And when I look at the two lists that I just put up, if I were an acute psychiatrist or working in acute services or general services, I think I'd be a little offended at some of the things there, as I would like to think that many of those values I would like, wherever possible, to include in my practice, and indeed they would be relevant to all aspects of psychiatric practice. So maybe the differences occur in other ways. Is it about the cohort of people that use our services? Is it about the stage of illness in which rehabilitation intervenes? Do we offer different types of treatment and treatment modalities? Is the workforce difference in terms of specialised skill sets? Or is there something about workplace culture so that those values that I mentioned at the beginning take on more prominence or are of more relevance for some reason? And I don't know the answer to all of these things, but I'm just seeking guidance from my readings and also hopefully from you. Okay, so we've talked a bit about rehabilitation psychiatry, and now just to talk a little bit about what specialist mental health rehabilitation services are. So I'd just like to mention a couple of these points or highlight a few of them. So we have a well-established specialist rehabilitation services in this state, and we deliver services to those whose needs cannot be met by less intensive mainstream adult mental health services. And I think the second point is really important. We tend to have a focus on people with severe and complex mental health problems who have high degrees of disability and high degrees of distress. Now, that's not to say that our services are exclusively for people with severe and complex mental illness, but that tends to be our main focus. We have the benefit of having a longer time frame, which means that really helps us to adopt a range of different treatment modalities, but also the benefit of being able to develop that all-important therapeutic relationship. And also, just to highlight again, the culture of therapeutic optimism. And you can see here the target population for our services. So it's really that small percentage of the population who have a mental illness, the small percentage who have severe and persistent mental illness. So that might be is commonly people with chronic psychotic illnesses who either have persistent positive symptoms or more likely prominent neurocognitive and negative symptoms. And the psychosis may be complicated by other comorbidities such as intellectual disability, substance use, or trauma, histories of trauma. And it stands to reason that when thinking about a culture of optimism, that these people have often had extensive journeys with mental illness that have had significant impacts on their capacity for social inclusion and makes it very difficult for them to access all of the goods that society has to offer that might be available to other people. And they've also had an extensive experience of treatment on many occasions with multiple admissions, some of which may not have been satisfactory for them. So that need to maintain therapeutic optimism and a sense that people can recover and should recover is kind of crucial in this context. And so I think that need for therapeutic optimism is foregrounded. So what you see here in this very confusing slide is what we have in terms of specialist rehabilitation care, what we call a complex care strategy in this state. And you'll know a lot of these services, but I think what's really important to highlight out of this is that we still have a predominantly inpatient bed-based service. So in New South Wales, we actually have close to 900 non-acute or rehabilitation inpatient beds, which, when thinking about trying to understand people in their social context and treat people in the least restrictive environment, it's kind of at odds with our philosophies to some extent. And in other jurisdictions around Australia, it's not that way. So in Queensland, most of the care in rehabilitation is delivered in the community. And in Victoria too, there's a large emphasis on community care. So New South Wales and to some extent South Australia are kind of standouts in terms of their dependence on inpatient rehabilitation services. Okay, so briefly just to look at the functions or what we might call the technologies of a rehabilitation service. So what are the actual interventions that we offer and deliver? And many of these, in fact, most of these have a strong evidence base for their effectiveness. So obviously psychopharmacology and other physical treatments are important. And certainly there is a large emphasis, and I know in my peer review group, lengthy discussions around the use of clozapine, supplementing clozapine when it is ineffective, the use of ECT, and also really managing the very real toxicity associated with clozapine and the other pharmacological agents that we use. But I think there are some really important interventions that we have more time to deliver that have a very strong evidence base. And they include CBT for psychosis, cognitive remediation, which is really well supported by the evidence now. And there is a multi-centre trial taking place in this state and Queensland to look at implementing that more effectively. Social cognition training, looking at enhancing or improving the deficits in social cognition that people with complex psychosis may have. And family therapy, which is a really a form of intervention that is well supported by the evidence, but where we're not really universal in rolling it out. Just to go down this list, vocational skills and training in individual placement and support is really looking at someone's occupational functioning in the community and the importance of having that social role. And again, it's an intervention that is well supported by the evidence. So this really is a non-exhaustive list of the treatments that we provide, which are a mix of psychiatric, psychological, occupational, therapeutic, and also psychosocial interventions, such as healthy lifestyle interventions. But are these exclusive to rehabilitation psychiatry? Well, I would argue that they're not, and that they could be used in any avenue of psychiatry and in any other context. I write co-design here as a way of really highlighting the importance of working with our service users at all levels, both in terms of their individual clinical journey and recovery journey, but also in the way services run and the design of services. So just briefly, I want to look at this term recovery because it's used a lot. I think there are multiple definitions. I myself find it very confusing. It's often confused with rehabilitation. And so I've put some definitions here which aren't definitive, but they just make sense to me. So I see recovery as an outcome, as a remission of symptoms, dysfunctions, and impairments in people with mental illness that that are contributing to their ability to experience a personally satisfying life. And that can be clinical recovery, can be functional recovery, or a personal recovery. And those three things could be very different. And recovery is a process which is about the introduction of values such as hope, and with the expectation that individuals will master their own disabilities and pursue their individual priorities. And I've just tried to make some comparison here between rehabilitation and mental health recovery, because rehabilitation, as you'll see here, in my mind, is a systems and professional-led set of services that aim to improve someone's skills and decrease functional impairment. And it's really kind of systems driven, whereas I see mental health recovery as a deeply personal and unique process that is helping to find people to find new meaning and purpose in their lives and quality of life beyond living with mental illness, or in fact, living with mental illness. So it's a much more personal perspective. And I really like this, this definition and the comparison. Rehabilitation is the supportive process, whereas recovery is the personal journey. Rehabilitation provides the tools and supports that makes personal recovery possible. Okay. In the last 5 minutes, I just want to talk a little bit about how we know we're doing a good job. First of all, just to preface this with this slide, which shows that rehabilitation services do their work. This slide's from the United Kingdom, and about these studies, the REAL study and the QUEST study, are quite old now. They're about 20, 25 years old. And they were undertaken at a time when there was enormous pressure on rehabilitation services in the UK to justify their existence, because they were going to be defunded. There was always that threat of being defunded. So they really had to show in a very tangible way that what they were doing was beneficial. And these two studies looked at their primary outcome measure being moving to living status or living conditions where people had attained more independence. So the REAL study was about moving from hospital care, successfully transiting into the community. And the QUEST study was about moving in the community from a place of higher support to a place of lower support and greater independence, as a proxy for measuring someone's capacity for independent living. And both of those studies showed very real, very tangible improvements in both of those measures. What I think, furthermore, is very important here is that they looked for particular variables that were associated with successful outcomes. And so in terms of successfully being discharged from long-term hospital stay, the variables of improved social skills, being engaged in activities in the community, and having a service that had a recovery orientation to their practice were three variables that were most strongly associated with a positive outcome. And for people moving from a higher level of dependence to a high level of independent accommodation in the community, and I hope that makes sense. The two variables most associated with success there were having a service that had a human rights promotion in its service, and also recovery orientation to practice. So it really highlights the importance of those skills development that we're talking about, and the importance of having a recovery orientation of the practice. Okay, so how do we ensure, and how do we know we're doing a good job? And I think there are many answers to this, but I've just listed here three ways that make sense to me. The first is to look at best practice guidelines and best practice models that have perhaps been developed by other services. The second is to consider some process of monitoring and evaluation of our own service, and I'll talk about that in a minute. And the third is benchmarking, which is finding services that more or less do the same thing to you, and comparing and contrasting, meeting and deciding what are the measures that are important to benchmark, and then learning from each other. So looking at the first point, which is around best practice guidelines. Well, we're very fortunate in that this guideline was developed by the National Institute of Clinical Excellence in the UK. And it's for rehabilitation for adults with complex psychosis. So in that sense, it is diagnostic specific, but it is a very thorough examination of the evidence to help create a template, if you like, for how rehabilitation services can be organised or should be organised, the processes of a good rehabilitation service, the interventions that should optimally be delivered, the culture of services, and also a focus on the physical health of service users. And what I really like about this is not only is it a very rigorous examination of the evidence, but it's an outward-facing document. So it's not just for service providers and clinicians, but it's also for service users, so that they can ensure that the people providing services to them have a standard by which they can measure their service. So just to briefly mention that the College of Psychiatrists has a working party, of which I am a member, and we're adapting this guideline for the Australian and New Zealand context. Hopefully we'll have that ready for broader consultation by the end of the year. Second, I'm sure many of you have heard of the New South Wales Inpatient Rehabilitation Model of Care Framework. This was developed after, again, an examination of the evidence and consultation, extensive consultation with experts in the field. And I really like it because I think it is going to help to bring some commonalities and some standardisation to services across New South Wales. It's not asking all services to provide the same thing in the same way, but it's providing a kind of scaffolding, I guess, a structure within which to consider what we do. And as you'll see there in this very busy slide, it talks about the key principles. It has articulated 3 broad subtypes of services in New South Wales that I think will be really helpful for benchmarking. It talks about the key processes, and they fall into 6 categories, and they're the processes of care. And then the 5 key enablers, which include not only governance structures and partnerships, but also talk about the nature of the physical environment, the relevant skills mix and staffing that is required, and also monitoring and evaluation. And so this slide is about monitoring and evaluation. And, I guess really we could look at anything that we choose. And depending on who we are and our perspective, what's important will seem different. So if you're a commissioner of services, if you work with the Ministry of Health, then perhaps the health economics are an important guide for success of a model. If you're a clinician, you may be interested in reduction in use of acute hospital inpatient bed days, or reduced use of emergency services, or the quality of the services that you're providing. But if you're a service user, your view on outcomes will be very individual and very personally driven by whatever your goals are that you're trying to achieve. So this slide, which is my last, I'm running out of time, is really an attempt by a working group to look at what would be an important values-based framework for evaluating the services that we operate. And I really like it, and I must say it's only a draft and it's nowhere near complete. But I like that it's values-based. I like that it's looking at measures such as the RASDS and Recovery Star that are very service user focused. I like that it's looking at the potential for trying to interrogate our services and the staff in our services, their recovery knowledge and how they translate that into practice. And also looking at very practical issues like what are the wait times to get into a rehabilitation service? How timely is the rehabilitation when it's provided, and is it being provided in the least restrictive form of care? So whilst this is just a guide and it's still a long way to go, I really like the work that's being done there. So look, I have used up a lot of time. Thank you so much for listening. I'm happy to answer any questions. Also, I might stop sharing actually.
Thank you so much, Nick.
It's
a really fantastic presentation, and I could see it was really resonating with the audience by the number of positive emojis that kept popping up on screen, almost distracting from your presentation. There were so many. But it's great. I mean, I would think most of us here would agree that rehabilitation psychiatry is a vital part of mental health care. And while service models have evolved, clinicians in public mental health settings often face significant time pressures, and recovery-oriented work can sometimes be sidelined. From your perspective, what practical strategies could individual clinicians adopt to carve out more time for rehabilitation-focused work in their day-to-day practice?
Look, that's a very good question. I think, it's something that really needs to, I think, be foregrounded and remain at the foreground of our thinking, really. And so I guess it's something that perhaps we, instead of doing as an individual, it's good to think about doing that at a team level. If your team has a process of reflective practice, that might be one of the key items to think about. And I think it's returning to an understanding of values, values-based care and what that actually means. So thinking about it in whatever processes of reflective practice or peer review you have, peer review meetings is another place to think about it. They're just a few suggestions, but I do agree that it's a real challenge, especially in many generalist services that are understaffed and under a great deal of pressure. and have very short timelines to sort of maintain that at the front of our thinking. But yeah, I guess I just ask everyone to redouble their efforts in that regard.
Yeah, great. Very, very wise answer. And hopefully that's something that people can go back and start talking to their teams about, embedding more of this recovery, rehabilitation focused work. Got quite a few questions from the audience. I don't know if we're going to get through them all, but let's give some of them a go. Question around service users who, for want of a better term, may not be rehab ready or not wanting to engage in a particular aspect of rehab. Any input into how that might be approached with an individual?
Yeah, that's difficult. I know that's really difficult. And I know it's when services, often there are limited places, especially in inpatient rehabilitation services, although it's not intentionally used as a way of excluding people from the service. It's understandable that a service would prefer to take someone who is much more accepting of participating in rehabilitation. Look, I think sometimes even if people aren't rehabilitation ready, and I'm a bit wary of that term, people can start to engage in rehabilitation services even when they remain under involuntary treatment orders. So I think it can start then, and then I think the work of the rehabilitation team is to really try and get someone on board with the practices of recovery. And look, I think that's one of the challenges and perhaps the art of the work we do is to allow people to see a future and move beyond their current circumstances to understand that things can be different and that they can have goals of their own choosing. And even if it's just one goal, such as getting a driver's license or completing a TAFE certificate or re-establishing a relationship, that can then become a kind of focus point for discussion and drawing people in a more kind of active and collaborative way. It's a very vague answer, but I think a lot of that really is part of the skill and part of the art of a good rehabilitation clinician.
Yes, no, thank you. No easy questions today, I'm afraid, Nick, just tricky ones. We're actually with the, we've got a number of other questions, which we might put you via email. And if you've got the capacity, we'll collate those answers and distribute them when we share the slides and the video of your presentation. So please all join me in virtually thanking Nick again for his wonderful presentation today. We look forward to welcoming you to the final webinar of 2025 in November, which will be presented by Associate Professor Brooke Short, who is the new Clinical Director of the Tertiary Referral Service for Psychosis, with the presentation Beyond Referral, Transforming Tertiary Psychosis Care. We will email more information about that out soon. And please, if you want to stay up to date with future events and webinars that Mindgardens is running, the QR code is now on the screen. Otherwise, we've just ticked over to past 1 o'clock. So thank you very much. We'll close the meeting there.
Thank you.